Welcome back to the second hour of LoveBabz LoveTalk on Babz Rawls-Ivy. This is the talking part. I am delighted to start to have this conversation because Harry and I have been talking about Black maternal health for quite some time on this show. And I said, oh, you know what? We really should have somebody on to talk about this. So I text my friend, Amanda Skinner, who is my friend and the president of the Southern New England Planned Parenthood of Southern New England. And I said, you know, I want to talk about this. Do you know anybody? She's like, do I know anybody? And so she connected me to you. This is Dr. Karen Sheffield-Abdullah, and she is a PhD, a RN, a CNM Assistant Professor at the UNC School of Nursing. Welcome. Her expertise is in stress and anxiety in Black pregnant birthing persons and women and the impact on their birth outcomes, in particular preterm birth. So, you know, Dr. Sheffield-Abdullah, Black maternal health care is on everybody's lips right now.
Sure
and we are seeing that no matter where you are economically, if you're a Black woman about to have a baby, you might be in some trouble.
You might be a little stressed. Yeah, you might be a little stressed, might be a little anxious. Absolutely. So thanks for having me on, Babz. I appreciate it. And thanks to Amanda for making the connection. And certainly, so I'm a nurse midwife. I've been a nurse midwife for 17 years and am also a mother of 4 and also a researcher.
Too.
Yes, there you go. And a researcher who looks at stress and psychological distress or anxiety in Black perinatal women and impact on their birth outcomes, in particular preterm birth. And so really, this topic is near and dear to my heart. It's been part of what I've really been passionate about for the last better part of the decade. And if you remember nothing else about this, I am passionate about women's health. I'm passionate about psych mental health, in particular anxiety, and I'm passionate about integrative health approaches, in particular mindfulness, and how the three of those things can kind of meld together. But as we think about Black maternal health, Black maternal morbidity and mortality, we know that, you know, Black women have 3 to 4 times the risk of maternal morbidity and mortality compared to their white counterparts. And in particular, as we think about preterm birth, which is my particular area that I'm interested in, we know that Black women have twice the rate of preterm birth and low birth weight compared to white women, despite controlling for different factors like socioeconomic status, maternal education, access to prenatal care. When you pair a Black woman and a white woman together, the Black women will always have twice the rate of preterm birth and low birth weight compared to white women. And this has persisted despite decades of research. And so what is it about the lived experience in this country for Black women that we persistently have these poor adverse outcomes? And furthermore, if you look at a Black college-educated woman, pregnant woman, and a white high school educated woman, the Black woman will still have the worst outcome. So there's really a lot there that I'm particularly interested in examining and really looking at what are the unique stressors that exist for Black women that we have overlooked that could be contributing to our birth outcomes.
So do we start with racism and then work our way back?
Like, well, hey, I think there's a, you know, there's a
start, Karen.
Yeah, well, I think there's a big part of educating folks that race is not the risk factor, right? Racism is the risk factor. As we think about what we call social determinants of health, it's not about a race a race or the amount of melanin in my skin that predisposes me to having poorer birth outcomes. It's about the social determinants, including racism, institutional racism, structural racism, interpersonal racism, microaggressions, the stress that comes at the intersection of being black, so black related gender race related stress and gender related stress, and how those intersect and what that means, right? As we think about black women and how we show up in the world and all the stressors that we experience across our lifespan, right? It's not just during the reproductive years, it's prior to pregnancy, and then how that's exacerbated or worsened during pregnancy and then persists even once we're no longer pregnant, right? So there really is a lot there. And in particular, preterm birth is a $26 billion cost to this country per year, and the
Wow.
consequences. So for that reason, it's very fundable, right? So institutions like the NIH and different foundations like the CDC, everybody's really interested in how can we move the needle on what is happening with Black women's birth outcomes. And certainly these things have been elevated when you have the Serena Williams of the world, right? When you have Alison Felix of the world, when you have the Beyoncés coming out saying, here's what happened with my birth experience. Now it's really been highlighted, I think, more so in the more recent years, which is why this is now a real push for the Biden-Harris administration, why Kamala Harris has made this, has elevated this issue surrounding maternal morbidity, mortality, in particular for the Black community. And how do we think about addressing it so that we can actually improve outcomes and not just talk about it, but be about it?
Mm. So how do we begin this conversation? Because if it's before we even think about getting pregnant, where does the interruption, or where do we step into the pipeline to disrupt what happens to us when we have babies? Like, where do we start this conversation, and where do we put in stop gaps to sort of ensure that we can bring our children to term? Like, where do we start?
Well, I think it depends on your perspective. So there are certainly multiple places that we can start, and different individuals have different perspectives on that. So some will say we need to start at the system, right? At the systems level, systemic, looking at the structure, right, of institutions, of hospitals, of insurers, what is happening at that level, right? Some might argue, well, we need to think about it from an intrapersonal perspective. What's going on with the healthcare providers, right? Are the healthcare providers educated surrounding the unique experiences of stress for particular communities, right? And are we having these conversations with nurses, nurse practitioners, medical students, residents, attendings, fellows? We need to be educating the healthcare community surrounding the very real biases that are just ingrained within the system,
Mm-hmm.
right? And having conversations about that and educating individuals on that level. And then just personally at the individual level, how do we equip African American birthing persons, birthing women? How do we think about helping them develop stress management strategies and coping strategies to deal with all of these stressors that come in our lives, such that we can decrease our stress, decrease our anxiety, decrease our depression, increase our quality of life, increase our well-being, in the hopes of improving birth outcomes. We know that stress leads to preterm birth. It's associated with preterm birth, and we know that anxiety is associated with preterm birth. So really what I'm passionate about is how do we really get at impacting stress and anxiety for Black women in the hopes of downstream being able to impact their birth outcomes or improve their birth outcomes. And so it depends on, where you want to begin, and how we look at that in terms of the education. Certainly I've been in conversations with professors, with medical colleges talking about how do we really think about educating our residents and our medical students surrounding the cultural context, the nuances of stressors for the Black community, right? And really thinking about how do you interact? How are you asking the questions, right? So in my research, in my formative early work, I did a study where I asked Black pregnant women, what is uniquely stressful about being pregnant? What is uniquely stressful about being Black and pregnant? And they told me. And then I said, are you having conversations surrounding your stress and your anxiety or depression, psychological distress with your healthcare providers, with your women's healthcare providers? And it's a resounding no. And I said, okay, would you have wanted to? And the answer was yes, but only if they have resources that I can really tap into that is going to help me, right? So don't give me, a referral somewhere that can't see me for 3 months, or don't refer me to a place that doesn't take my insurance. Furthermore, don't refer me to somebody that isn't stellar or good at what they do. They don't want mediocre healthcare providers. They want somebody that's really going to provide excellent care, right? And so really leaning into that and trying to figure out how do we start to navigate those conversations. In my work, when I ask Black women, when I say the word stress, what comes to mind? Because nobody had asked that question, right? So we all think that we have the answers for how to best help a community. But if you haven't asked the fundamental questions, like what's stressful for them and how do they define stress? Nobody had asked Black pregnant women through the particular framework that I was utilizing called Superwoman Schema. And we can talk about that if you want to. But really, I asked them, when I say the word stress, what comes up? And they said, overwhelmed, overloaded, anxious, right? And so that was really important to me because I knew anxiety was a thing, but nobody really wanted to talk about it. Everybody was like, oh, Karen, you should look at depression. You should really include depression. And I was like, listen, anxiety is a thing for this community and we're not tapping into it, especially during pregnancy. We studied depression a lot, postpartum depression, depression during pregnancy. We do not study anxiety nearly as enough. And what we do know, the data says that anxiety is more prevalent during pregnancy than depression, but we're missing it. And so how do we navigate that conversation? And what was really interesting with my work is that the 130 Black pregnant women that answered my surveys, 27% said they were anxious, followed by 23% admitting that they were depressed. That's significant, especially within a community where mental health is stigmatized. For that community, for those women to admit and say, I'm anxious and I'm depressed. And what do we do about that, right? And so having the conversation with them that would really help me to understand, what are you anxious about and what are you depressed about? And are you talking to anybody about it, right? And what came up was, well, I ain't gonna talk to people and open up all my business, right? And then people want to, the DCF shows up or social services shows up and they're gonna take my baby at the hospital. Like there's a vulnerability that is very hard to get past in developing trust with the healthcare provider for Black women. And if we develop that trust and we let down that guard or that stoic exterior and reveal something to individuals, we want to feel that that space is a safe space or a space where at least we can show up and be authentically who we are. Now, you notice I paused there with safe space because I don't know that we can really create a safe space for individuals, but I know that we can create a brave space, right? Where people can show up authentically as who they are and what are the very real stressors that exist for them and want to know that they are being seen, heard, and valued, period.
So does it make a difference if you have a provider that looks like us?
That's a great question. I love it, Babz. So I'm doing a study right now where I am looking at that very issue. So I'm looking at racial concordance whether or not it matters, whether or not Black women have a Black healthcare obstetric provider. So asking that fundamental question, does it matter? Does the race of your provider matter? So there are studies that have been done within the primary care setting that looks at the importance of racial concordance between primary care providers and Black patients, but nobody has looked at it within the OBGYN space, within the obstetric space. So that's where we're really interested in finding out, what is this important or not? So we asked them to fill out 3 different surveys: a perceived discrimination survey, a perceived racism survey, and a contextualized stress survey, right? And 200 women have done that. And now we're doing one-on-one in-depth interviews, asking questions with them, right? And asking them, have you experienced discrimination during your pregnancy? Have you experienced discrimination in your life? How do you identify racially and ethnically? And then, have you experienced discrimination during your pregnancy, during labor and delivery, during the postpartum period? And what did your providers look like, right? Did they look like you? Did that matter? And did gender matter? And we're getting all types of really interesting information and about what is important to Black pregnant women regarding the race and ethnicity of their providers. And so it's unpublished data. I'm still collecting that data. Stay tuned for the answers to those questions.
I am. Because you know what? Because it was, just as you were talking, Zora Neale Hurston comes to mind. All our skin folk ain't our kinfolk. Right. So maybe you might have somebody who looks like you, but they show up with white supremacy written all over them, in their execution.
That part, because I think that's the other thing. People are like, oh, Karen, why do you have to put a study to this? We know it's important, right? We make these assumptions that it's important, but you have to ask the fundamental questions to really figure out. That's the beauty of science. That's the beauty of research. That's why I'm a researcher. Putting the science to the question. Is it really important? I have assumptions about that, but nobody's asked the question. So let's ask the question. And
because I know some Black folks who I'm not going to spend that much time with because white supremacy. But I know some white folks I'll spend all day with because they about it. Do you know what I mean? Like,
absolutely know what you mean. They won't. They know what's up, right? And they can position themselves with, I find that those individuals, those healthcare providers that I appreciate interacting with who are white, show up saying, I am showing up as with my privilege. Not really admitting that I cannot truly understand your lived experience, but I'm here to understand. I'm here to learn. I'm culturally humble, right?
I like that.
I want to get it right.
So what I'm interested in is, how do we talk about anxiety and depression with pregnant women and pregnant persons without it being turned and used against us for the loss of babies and not being able to, just when we lose our children in this manner? How do we not internalize that as, I've done something wrong? It is me that is the problem here. Do you know what I mean? Like, how do we get women to sort of do what you say when they're in with their providers, to open up, to be vulnerable, and to say this, that, and the other thing? And then how do we get women not to internalize these losses to the point of continuing down this road of anxiety and depression, unspoken anxiety and depression?
Yeah, and so when you say losses, do you mean loss to the system because DCF or social services gets involved and their baby gets taken away, or do you mean loss in terms of like baby not surviving?
I think both, because I know that is a real fear with women, with people losing their children to DCF. That's a real. I mean, all my children are adopted, right? I have 4 children, they're adopted. So I understand something about children being taken away from birth parents. But I also have friends who have lost children, and that grief of that has been internalized. Like, I must have done something. This is my fault. Why can't I do this? People have been doing this. Black women have been doing this for thousands of years. Why am I the one to not be successful?
Mm-hmm. Mm-hmm. Yeah, so there's a lot there to that question.
Yes.
What I would, well, because perinatal loss or loss is a whole different realm of I think of just understanding and lived experience. Black women who are experiencing perinatal loss or loss during pregnancy, or even after, delivery, baby passing away, that's a grief um, that is unique all to itself.
Mm-hmm.
And I think requires its own attention in terms of how we really think about what I would say holding the container, holding space for Black women who've experienced the loss. Here's why. Black women are suffering in silence, especially when it comes to loss. We're not talking about it. So I had a conversation recently with a Duke psychologist who was saying, Karen, Black women are suffering when it comes to their loss. They are not talking about it. They are feeling isolated. And I can absolutely share with you that as somebody who at 43 myself went through a miscarriage, and I was well educated, healthcare provider, had support, extremely isolating. Because the depth of grief that comes with that is so profound. And you also feel like I am the only one that's going through it, even though you know that folks miscarry, but nobody really talks about it around you. And then once I started saying things to others, they were like, oh yeah, no, I went through that, a miscarriage as well. That's really tough. But I was like, well, where y'all at? Where you been? Because wasn't nobody talking to me. So I felt like I was going through this completely alone.
Mm.
And in fact, even thinking about the miscarriage itself, when you couple, as I was thinking about how excruciatingly painful the miscarriage was, which I was not prepared for, even though I had counseled hundreds of women over 17 years through that process. I myself wasn't prepared for how painful that was. And when I talked to my healthcare provider, she highlighted, she was like, oh, Karen, pain is one thing. Pain with grief is something completely different. And so there was this combination that I don't think I was prepared for, but it made me a better healthcare provider. And so it's really illuminating that for healthcare providers, right? And also educating, not only educating healthcare providers, but family members about the importance of having these conversations surrounding loss. As we think about navigating anxiety and depression within the healthcare system while pregnant as Black women, that's a whole nother layer, right? A whole nother level. How do we have those conversations? How do we get past that? I think some of the onus is on healthcare providers. We got to do better. We got to do better at like having time to actually sit down and talk to folks, right? Instead of packing our visits with 15-minute slots, right? And you're in and you're out, you're barely sitting down, you're barely even scratching the surface as to what's going on for an individual. And then if you do scratch at the surface and then they divulge that they need some help, do you have the resources immediately available? Do you know how to hook them in, right? And can you do that in a way that is non-judgmental? Right?
Wow.
And that comes through education. That comes through what it is that I'm wanting to do. That comes through what the work is that I'm wanting to elevate as we think about educating healthcare providers about navigating these hard conversations and making the time, right? Making the time to ask the question. And I will say that part of the reason I went back for the PhD is what I was seeing in clinical practice. A lot of my patients were sharing with me that they were anxious or depressed, but they didn't use those words. And that's the importance of what healthcare providers need to understand. Black women aren't necessarily going to come to your office and say, I'm anxious or I'm depressed. You need to be educated in the unique ways, the contextually relevant ways that we navigate those conversations. right? So a lot of times individuals were coming to me talking about, I'm just real irritable. I'm tired, cranky. Folks just getting on my nerves, right? And
I just said that yesterday.
right? They're stressed, right? And they're stressed. And what I was finding is that people would say, well, back in high school, I had like situational depression, but I don't have anything now. Or I just take a little bit of my mother's Xanax, right? They would tell me things like this, right? They're taking a little bit of their mother's anti-anxiety medication or their grandmother's anti-anxiety medication, but they weren't formally diagnosed. And I listened and I held space and I was like present, fully present, right? And what I found is that I was building a practice where I was seeing a lot of patients for their psych mental health concerns. And I'm not a psych mental health care provider. So what I would do is get them started. Within my scope of practice as a midwife, I certainly can prescribe medications, right? And follow up with them regarding how they're doing. But medication works well. Therapy works well. Medication and therapy works great, right? But thinking about how many, if we're talking about racial concordance, I can't tell you how many individuals, how many Black women over the last 3 years alone, right? Because it's been a whole dumpster fire, like of a mess of a world over the last 3 years that have stressed women out and were anxious. And how many people have said, Karen, do you have the name of a Black mental health care provider? Because
oh yes,
right.
Girl,
and
yes.
There's just not a lot of us out there, right? And so what I want us to think about is not just the psychiatrist, it's not just the psychologist, but we need to think more broadly. And we need to be inclusive of licensed clinical social workers, psych mental health nurse practitioners, right? That way we're expanding the scope, the bucket, if you will, of mental health care providers, which will then increase the likelihood that we'll have more that would be racially concordant or of color, right? So that's one thing to be thinking about. And also, like I said, really being able to have the resources available in a way that is respectful and that is trustworthy for when Black women divulge, share that they are struggling with their mental health, right? And so when I asked about whether or not their providers were asking them about their stress or psychological distress, they said no. And I asked them what they want to be asked, and they said, well, only if they had resources. And I said, well, how? And occasionally somebody would say, yeah, they asked me about my depression and they asked me if I was sleeping a lot. But if you ask me, sleep doesn't have nothing to do with it. If I'm depressed, I just like to sleep, but I'm not depressed, right? So we really need to think about the scales or the screeners, the depression scales, the anxiety scales that we use, the questions that they're asking. Are they culturally relevant? Do they really apply, right, for the Black community? Probably not. Right? And so that's another aspect of the work that I'm wanting to do, to be able to develop culturally relevant anxiety scales, right, for Black women, culturally relevant depression scales for Black women that really get at whether or not we're depressed, not these kind of generic scales that were based primarily in white participants, right?
You know what? I'm very interested in, because I love this concentration on anxiety and overwhelm. Yeah. And the ways that we don't talk about it, or the ways that we do talk about it in the language that we are, when we with our girlfriends or whatever.
It sounds like I'm tired.
Have you ever met a Black woman who is not in overwhelm, who is not having some of this? I've never seen it, so I don't. The very nature of us, we are doing way too much. But what is the too much part? Like, where is that? Like, how do we not do too much?
Yeah, so we're doing the most, and how do we not do that? Yeah, certainly I have met Black women that are better at finding. I'm not using the word balance anymore. I'm using the word
harmony. I hate that word.
Right?
Because it's just crazy to me.
Right. Balance, like I got 15 things. So when I think of a balance, I think of a scale. I think of two things, and there are two things. I got way too many things going on. And so I actually think about, can you achieve harmony amongst all of those things that are going on in your life? And yes, there are individuals, there are Black women who are able to do that, right? And it has to do with their resilience, it has to do with their coping, it has to do with their stress management skills, perhaps their mindfulness. I'll put that mindfulness out there again. But for individuals who have found out what helps them, right, be able to find a better harmony within their lives. But you are right. From the majority of Black women who are, as I say, slaying lions every day, we got a lot going on, right? So we are already baseline. Our baseline is a fair amount of stress, right? And so when we think about stress, we think about what's called kind of cumulative stress, or the weathering hypothesis, or allostatic load, where it's stressor over stressor over stressor over stressor over long periods of time, such that when you ask us if we're stressed, we might say no.
Because we've been living with it for so long that it has become part of our everyday practical lives.
That is exactly right. And so we have found some of that in our racial concordance study, where I asked Black birthing women, was your pregnancy healthy? Was your pregnancy healthy? And they're like, yeah, no, it was fine, it was good. And then we would get through, more of the interviews, and they would be like, well, I bled most of the pregnancy. And then I had to have an emergency C-section, and then I had a hemorrhage, and the baby had a tumor on its liver. And I'm like, but you just said that that it wasn't stressful, that it was healthy. Do you see what I'm saying? It's because the baseline of what we are used to handling is so high that we don't even consider all of the other stuff. Oh, my baby had to stay in the NICU, in the neonatal intensive care unit. That's just like parenthetical for 7 weeks. And so I did reflect back for one individual, and I said, so I just want to reflect back what I'm hearing you say. So it sounds like, you bled most of the pregnancy, and then you ended up having to have an emergency C-section, and then you had a hemorrhage. And then it sounds like there was something going on with the baby, and the baby was in the NICU for 7 weeks. And then by the way, the next day they came in and asked you if you were ready to be discharged after 24 hours. And during the interview, she had her camera off. And at that part, she turned her camera on, and she goes, "You heard me. That's exactly right." And to reflect it back to her, I think she realized just how ridiculously stressful and anxiety provoking that entire experience was. But at the end of the day, she was like, well, I'm just happy that my baby is okay. Right? But it's like, we need to want more from our healthcare providers, from our hospital systems. That's not okay.
Yeah.
That's not okay. And so how do we start having conversations with Black women such that they realize, I'm going to advocate for myself. This is not all right. You know what I mean? And doing it in such a way that allows them to get the resources, to get the support that they need to get. And it has to happen within an environment where we have also educated the healthcare providers, right? So don't just ask a Black woman if she's anxious and depressed, because you're probably not going to get the answer that you're looking for, right? And from my studies, one of the participants says, Karen, if you really want to know what I'm anxious about, you want to know what I'm stressed about, ask me what I'm Googling.
Ooh.
That's how you're going to find out what I'm stressed about. That's it, right? Ask her what she's Googling. If she's Googling Black women's pregnancy outcomes, oh, she's stressed because she's thinking about preeclampsia. She's thinking about, hypertensive disorders of pregnancy. She's thinking about diabetes. She's thinking about, is she going to die? She's thinking about whether or not the baby's going to die. Is the baby going to come early? Is the baby going to be too little? Is the baby going to be too big because she has diabetes? Those are the things that are causing her stress and anxiety. But if you just ask her outright, is she stressed or anxious, you may not get to the answer that you're looking for. And so it's really having the conversations at the medical student level so that then they're learning it early and carrying that through residency, right? Carrying that through the fellowship. Having that conversation at the nursing level as a nursing student, right? And then at places like my alma mater at Yale, where I met Amanda, right, as a accelerated 3-year master's in nurse midwifery at Yale School of Nursing, having conversations with those individuals, with nursing students, right, who are wanting to go into nurse midwifery or women's health nurse practitioner, How are you having these conversations with the Black community in a way that is holding space so that they trust you and are able to share with you what exactly is going on with them? Yeah.
Wow. This has been a fantastic conversation, Karen,
Yeah.
Dr. Sheffield-Abdullah. You have to come back. You
Yeah,
just
I'd love
hands
to.
down have to come back, and we have to have more time
Yeah.
unpacking some of this, because you've illuminated a couple of things that I want to come back around to, and
That would be great.
I want you to come back to talk about this.
I'm fired up. I'm ready. Yeah, yeah, whatever you would like to talk about, Babs, because I really feel that it is important, and, it's hot right now, but to be perfectly honest, these disparities have existed for decades, folks. I recognize how important it is, to highlight and elevate this, but I've been doing this research for 8 years, almost a decade. It's just now getting to where everybody wants to be talking about it, because it's affecting and impacting individuals that we wouldn't think it would impact, right? More affluent, well-educated, higher socioeconomic status, Black individuals, right? When we have pediatricians who are passing away in childbirth due to, preeclampsia, or, you know what I mean? Like, really paying attention to, Serena Williams having to advocate for herself, yet nobody was really
in the hospital while she's there, like,
saying, excuse me, when you gonna give me my blood thinner, right? Like, I have blood clots. I know I have blood clots. I have a history of blood clots. I have a blood clot now, I'm pretty sure, and not being listened to, right? And if she's not being listened to, what does that mean for those that don't have her prominence, that don't have her status, right? That don't have her access to resources, to low-resourced individuals? How do we advocate for those individuals so that they feel empowered to advocate for themselves?
Girl, we could do this all day. I'm telling you. I'm definitely going to see you some dates, because I want you to come back, because this is way too important to let go. And you've got me excited.
Yeah, absolutely.
Thank you so much. And Amanda Skinner, thank you for the introduction.
Good people.
Thank you so much. Enjoy the rest of your day, and I will be back in touch. Oh, I feel so much smarter. Thank you. All right, Harry, play us out. We'll be back tomorrow, good people. I know I have a guest, but y'all tune in tomorrow and you'll find out who it is. I'll see y'all.
Mm-hmm.